Well, hello everyone, and welcome to our CASE conference webinar via the Academy of Consultation-Liaison Psychiatry. I'm Dr. David Fipps. I'm a CL and addiction psychiatrist at Mayo Clinic, and I'll be moderating this event and introducing our speakers. Just as a reminder, this event is one of many in a monthly series of alternating CASE conferences and educational webinars, so be on the lookout for some of the upcoming events. But today's 30 to 45-minute CASE conference, representing the Telepsychiatry SIG of ACLP, will include a brief case presentation by a trainee, followed by a facilitated case discussion with a CL faculty member, and then end in a Q&A session. So if you have questions, please put them in the Q&A option. Feel free to use the chat if you would like for comments, but we will only be answering questions inputted in the Q&A section there. So let's talk about our speakers. Our trainee presenter today is Dr. Julia Rhodes. She's a PGY4 psychiatry resident at the Medical University of South Carolina. And our faculty discussant today is Dr. Andrew Alkis. He is a clinical assistant professor at the Medical University of South Carolina, and he is now the chair of the ACLP Telepsychiatry SIG as well. And so without further ado, I will hand it over to Dr. Rhodes for her presentation.
Thank you, Dr. Fipps, for that introduction. I'm really excited today to share with you a case that I encountered during my outpatient year where I was learning how to treat agoraphobia in the virtual setting. And so the case begins with my patient who presented originally with just the chief complaint of, I can't go outside. He said he had anxiety when he was leaving the house. I soon learned that that was significantly more of phobia than he originally let on. So this was a 30-year-old male with a past psych history of generalized anxiety disorder and social anxiety disorder in childhood, who presented with worsening anxiety whenever he tried to leave the house. So he would experience these panic attacks when he would first open his door to try to leave and go outside. This had resulted in him not being able to leave his apartment complex in the last 5 years at the time of presentation. He had been able to go outside and get to his car, but he started reporting he would experience overwhelming panic whenever he stepped outside, and then especially whenever he was thinking about just the vastness of the universe and the sky above. And so at the time of presentation, he hadn't been able to sit in his car and drive outside of his parking lot for 6 years at the time that I met him. So his psych history was significant for ADHD and childhood, also generalized anxiety disorder and social anxiety disorder that he had seen a therapist for. He was diagnosed with panic disorder in childhood. He remembers his first panic attack being 5 years old when he was laying down in a field and looking at the space and sky above him. He also had PTSD. The longer that we spoke to each other, the more I suspected. He had a self-reported diagnosis of autism spectrum disorder that he had never gotten a formal diagnosis for, but I suspected it to be true. His treatment, he had tried various SSRIs, not SNRIs. He had tried benzodiazepines before when he was still able to go out into the world, and he briefly tried CBT in college for anxiety. He had no prior hospitalizations, no history of suicide attempts or self-harm, had never had an intervention like TMS or CBT. I'm sorry, TMS or ECT. He was not on medications at the time that he presented to me. His medical history was significant for class 3 obesity at the time that I met him. He had stopped attending college in person halfway through, and he graduated, got his degree virtually, and then went on to get a master's degree online virtually. He worked full-time at the time that I met him for a bookstore chain doing tech support. He also lived with a fiance who was very supportive of him and who was able to leave the apartment. They had no children. He had no tobacco, nicotine, drug, or alcohol use, no history of substance use. So his childhood trauma was very significant for this domestic violence between his mother and biological father that he witnessed from birth till he was 5 years old. He remembers police being called. He remembers firearms. There was one night where mom escaped with him and his brothers to uncle's house when he was 5 years old. He had never left their house to like go stay with a family member before. So that was his first time traveling. And the biological father followed them and attacked mom in front of patient enough that EMS was called and mother was hospitalized. He had a family history of alcohol use disorder in father, and then major depressive disorder and PTSD in mother. There was no family history of suicide. So his mental status exam was really only significant for how appropriate and linear he was. He had good eye contact. He had appropriate virtual courtesies. And he would always say he was good and had a normal range. At times, he was artificially bright. And his thought content and perceptions, he never had any auditory visual hallucinations and no delusions, no paranoia. The only time he would become, in his thought contact, become irrational or illogical is when we would talk about these phobias. What would happen to him if he stepped outside? What would happen to him if he was underneath the sky? And the loss of control that he would felt. He had fair insight into his condition, into the severity, and his judgment at times was fair, and at other times was really limited as far as his ability to or his desire to want to engage in some of the exposure therapies. So the medical workup, I had wanted to run the standard panel on him: CBC, CMP, hemoglobin, lipids, thyroid, B12, folate, vitamin D. I specifically really wanted to see electrocardiogram. I was curious about a urine drug screen. I was unable to get any of these labs. This patient was declining to leave his apartment complex. There was a PCP about 3 blocks away from him. So my differential for him, I was pretty clear on the diagnosis of agoraphobia. He met criteria for. I also diagnosed him with panic disorder. He was very afraid of inducing another panic attack, and whenever we would try these exposures. The social anxiety disorder was historical for him, but a lot of his isolation came from not wanting to be around people. And then I suspected his post-traumatic stress disorder was playing a bigger role in these in his experience with panic than was otherwise noted. So I do suspect autism spectrum disorder in this patient related to his childhood difficulty with socialization and his preferences in regards to textures and things. He would have heart palpitations during and after the panic attacks, and without any further investigation into the heart palpitations, I couldn't just say that that was panic and not something else going on. And so I was concerned about another medical condition for him. And so this patient brought up a lot as a trainee, as a first time trying to do therapy, a lot of questions for myself, like how do we navigate these unique complexities of a diagnosis like this related to telepsychiatry without the ability to be able to do in-person exposure therapy, without being able to see the patient and get a better picture of what's happening. And then are there certain medications that are too high risk to prescribe without seeing the patient face to face? South Carolina law made it possible for me to be able to prescribe controlled substances virtually without seeing him. And historically, one might consider doing benzodiazepines or propranolol for exposures, but as a trainee, I was really concerned about trying to do this without having any labs or seeing the patient. And then, what are the regulatory aspects of telepsychiatry care delivery that we need to be mindful of? Are we providing care that helps this patient? Are we hopefully not, but maybe affirming the phobias by doing this virtually? And then I had really thought about leveraging a relationship with that primary care just a few blocks away to provide better care for him, to see if he could at least get to that point. And unfortunately, we're not able to get to that point, but could that be something we do in the future? And so with that, I would like to pass this on to Dr. Alkis.
Thank you so much, Dr. Rhodes, for that excellent presentation. All right, so this has been a very interesting case to learn more about, and I was excited that she was open to sharing about her experiences with this patient. The case highlights the difficult balance we sometimes walk between extending care and making sure the care that is being extended is the most appropriate for the individual patient. It's undeniable at this point the positive impact telehealth has had on psychiatry. Champions like Dr. Terry Rabinowitz have been carrying the flag for telepsychiatry for decades, working to extend care to individuals who otherwise would not have access. I do think it is important to note that just because we can do something doesn't always mean it's the best approach. Over the last 2 decades, the pace of telehealth expansion has been exponential, considerably precipitated by the COVID-19 pandemic. While consistently utilized and repeatedly shown to be an effective treatment modality for numerous DSM-5 mental health disorders, I think it makes sense to question if there is any sacrifice to quality of care when delivered virtually. There are also several interesting questions that stem from this method of treatment delivery that we need to be mindful of. The differential in this case truly did remain a differential for reasons Dr. Rhodes shared. We could not obtain additional diagnostic testing or evaluation for our patient, including physical exam. Despite this, I think it makes sense that the most likely diagnosis, or primary in this case, is agoraphobia, based on several core features that were present. The individual endorsed pronounced fear of being in certain situations and environments. The cognitive ideation associated with the fear was consistently, how can I get out of this situation, or how could I get help if I need it? While panic attacks are often a part of agoraphobia, they are not necessary to make the diagnosis itself one of the changes with DSM-5. Given the avoidance variable here, I think it can be appreciated how, at least as a starting point, telepsychiatry can allow for establishing care and treatment plan development in hopes of moving toward more thorough evaluation and management, as well as engagement in the community, which is something the patient did desire in this case. I think it's interesting how making it to an in-person psychotherapy or psychiatric follow-up appointment could be implemented in an exposure hierarchy, with telepsychiatry providing the bridge to in-person care. There's robust evidence supporting treatment of agoraphobia using virtually based psychotherapy. One particular study by Bouchard and colleagues showed improvements with virtual psychotherapy comparable to face-to-face in-person psychotherapy. There are now different digitally based CBT treatment modalities that could serve as a way to improve anxiety and help the patient reappraise interoceptive awareness so the patient is able to make improvements, in this case at home, to start the process of treatment. This takes a lot of motivation and insight on the patient's part, as well as a good understanding of the patient's ability to sense how their body feels when anxious or in distress. One aspect of telepsychiatry that still makes me nervous is prescribing certain medications without being able to examine the patient. With regards to antipsychotic prescription, not being able to complete an abnormal involuntary movement scale, or AIMS, is something to be mindful of. We do have some evidence that supports accuracy in identifying abnormal movements through telehealth comparable to in-person. Given how successful the implementation of telestroke has been, it's not surprising that a significant amount of the evidence we have supporting assessment of physical exam findings through telehealth comes from our colleagues in neurology. While gauging severity of movement disorder symptoms was not a major component, Liu and colleagues showed neurologists were successful in recognizing movement disorder symptoms with high sensitivity, specificity, and accuracy. Of note, the majority of those cases were centered around Parkinson's disease, which is a specific patient population. Video-based AIMS assessment has been utilized by some providers with success, but may take some nuance and training for the provider to adapt the assessment, largely ensuring the patient is fully visible for the assessment and giving them instruction to move about or do various different things during the assessment. There's also a questionnaire called the MIND TD that can help guide clinicians through virtual assessment of involuntary movements, as well as understanding the impact of any functional limitations that result from these movements. Recommendations do persist for in-person assessment every 6 months if feasible. Involuntary movements aren't the only physical exam finding made more challenging by virtual assessment. If not able to evaluate for fever, tachycardia, hypertension, abnormal muscle tone, reflexes, fully assessing risk for certain medication side effects is going to be a challenge. In my practice, I try to view each patient and each medicine as its own risk-benefit analysis and stratify risk in the best way I can. While there are risks to certain classes of medicines prescribed without face-to-face evaluation, There is also risk to untreated substance use disorder, psychosis, or a myriad of other mental health conditions. In these cases, a source of collateral can be extremely helpful, even at times using the collateral informant as a tool for assessment if they feel comfortable. This also introduces the primary care provider into the equation. They're a huge ally for us, obviously, in the practice that we do. And if the patient can regularly follow up with their primary care provider in conjunction with telepsychiatry visits, this could allow for a blending of treatment modalities that best fits the individual patient. Controlled substance regulation has been a very difficult area to track over time, particularly since the pandemic. Over 15 years ago, the Ryan-Haidt Online Pharmacy Consumer Act established that controlled substances could be prescribed by a telemedicine provider, but the patient required an in-person evaluation first. The pandemic showed a relaxing of these guidelines, which have been extended federally through the end of this month. While many experts think this flexibility is likely to continue or even may be made permanent, there is always the chance that this may not be the case. Also, it is extremely important to be mindful of both federal and state rules and regulations. In South Carolina, despite the public health emergency and DEA relaxations, it remained against state regulations to prescribe Schedule 2 and 3 medicines without a face-to-face evaluation within a certain time window. This did change in 2024 for my state, but even with this change in state legislation, there is still confusion and disagreement over the interpretation of the state law. All of this to say, it is important to know and follow federal, state, and organizational rules and regulations. The frequent concern that may arise is what to do if asked to assess a patient who is located in a state where the provider is not licensed. A helpful resource I learned about at our recent annual meeting is the Interstate Medical Licensure Compact. If you live in one of these blue states, the compact is available to help streamline and expedite the licensure process in other participating states. While this would not be a solution for an immediate or emergency scenario, it is available to help if you're a provider near other states where a patient may reside or frequently travel to. I learned about the compact from Dr. Christine Fenn at Dartmouth, who described the importance of being able to practice in New Hampshire and Vermont given the state's close proximity. I do think there is an interesting challenge to consider if you're working with a patient who is currently out of your state of licensure. This may be a grayer area under certain circumstances, but for instance, if the patient is in crisis and you have a long-established relationship working together, what might you do? There could be potential harm that comes from not at least trying to direct that individual to emergency services where they may be. I encourage following all appropriate guidelines, but also consider there may be a difference between an evaluation and management visit with somebody in a state where you are not licensed and a phone call with an existing patient who needs support accessing emergency services where they're currently located. In challenging telepsychiatry cases, I think it's important to think outside the box, and I think leveraging our relationship with primary care as a means of ensuring patients are accessing effective mental health care can help balance some of the difficulties that arise in the virtual space. This made me think of the collaborative care model and some of the ways many COCM programs have incorporated telehealth technology over the years, in particular for rural settings. There's a shortage of mental health providers made worse for rural communities by congregation of mental health providers in larger, more urban areas. If you have a state that is approximately 35% rural, like South Carolina, telehealth-enabled collaborative care may not only extend mental health services to those rural communities, but also provide a much broader applicant pool for behavioral health teams to pull from, given the BHCM or psychiatric provider doesn't have to live in the specific area they are serving. I know I likely don't need to go into too much detail on the collaborative care model, given this is an ACLP webinar, but I do think it highlights an important aspect we considered with our case. Would the patient be more comfortable seeing a primary care provider as opposed to a psychiatrist or mental health provider? While not always the case, stigma may influence a patient's comfort level with where they would like to be seen. This is something we hoped would be the case for our patient. Wanted to leave you all today with some resources that have been extremely helpful for me as I continue to try and stay on top of the ins and outs of telehealth rules, regulations, policies, and innovations. The Center for Connected Health Policy is a wonderful resource for tracking some of the recent changes that have been going on at the federal level. The National Consortium of Telehealth Resources Centers has been an immense help to me in my education about telehealth care in general and service delivery. The consortium is made up of individual regional telehealth resources that have more specific resources for its collection of states. And with that, I would like to hand it back over to Dr. Rhodes to provide us with an update about our patient.
Thank you so much, Dr. Alkis. So to continue with this patient, we were able to do the exposure hierarchy and get to the point where we had left the apartment complex to go immediately right outside into the Dunkin' Donuts and wait in line. Unfortunately, during one of the exposures, he was waiting in line at the Dunkin' Donuts, felt trapped, had a panic attack. Because we were not in person, and he was on the phone. We were not in a visit, and he had trouble de-escalating himself to the point where it would traumatize him, and he from then on refused to do any further exposures after that. So we, after the first few sessions, we would do all of our visits outside. He would sit outside at a picnic table, and that's underneath an open sky, and we would have our sessions there. We would do visualizations of exposures instead of physical exposures during sessions. And then when we would do box breathing, if he panicked, but if he became resistant or overwhelmed, we would talk about his treatment goals, remind him of what he really wanted. To this day, he continues to be homebound. I've since transitioned out of that rotation. He is with another resident. He has widened his safety radius. He does go to Dunkin' Donuts at least once a week. He won't go inside, but he'll stay in his car. Unfortunately, he has not been able to go see that primary care office that's 3 blocks away, but has talked about making it his next goal. And with that, I just want to thank Dr. Fipps and Dr. Alkis and the Resident Education Subcommittee of ACLP. And with that, I will turn it over to Dr. Fipps for questions.
Excellent. Thank you very much. A great case presentation and an excellent discussion section. So for our audience members, this is where our Q&A session begins. You can use the chat if you want, but we will only be answering questions that are inserted in the Q&A option for our panelists here. And so one that came up and that comes up quite frequently when we're having some of these conversations, you kind of already discussed a little bit about more emergent needs and urgent needs when you're seeing a patient through a telehealth system. A very common question that comes up is regarding if a patient is endorsing suicidal ideation during their telehealth encounter. Can you discuss maybe how you might navigate the care delivery if someone has active suicidal ideations while you're on the call with them and you're nowhere nearby to them?
It's a fantastic question, Dr. Fipps. These situations are never easy to navigate, and they always do feel unique, but I think a few principles can be quite helpful. I think one, keeping the patient on the call while trying to obtain some source for collateral information. If there's somebody there with the patient, if there's someone that we can contact, a family, a friend, to help be at the side of the patient during the assessment, I think certainly we make it a priority as well. Probably should have said this first, of getting a sense of where the patient is. If we can confirm that, it's actually built into our platform before our patients sign on for visits. They have to input their current location so that, in the event of an emergency, we can find them. That part is certainly important, but also, we've debated this a lot at our institution, but we think that the best route, given that you may be working with people in different parts of the state, which is the case for the work that I do, we encourage, or we'll call the local sheriff's department in the locale of where the patient is, rather than turning to just calling 911 where we are, because that's probably not going to get us connected to the best resource. But also, contacting Department of Mental Health can sometimes, I know they do great work, and it's just sometimes difficult for them to get there on time. So collateral, location, and sheriff's department would be my recommendations to try to make sure that patient's getting care as quickly as possible.
Definitely a difficult situation, and just like any emergent care, it's difficult when you're not in person with them, but certainly methods to address it, at least. And kind of from that same context, the whole concept behind telehealth possibly has some correlations to even enabling or reinforcing some behaviors, especially in this situation. Actually, this individual was potentially avoiding social contact. Was there any concern first about that. Were you present on the phone when they were exposed to anxiety-provoking stimuli, even? And how would we address specifically using a modality that could almost be enabling or reinforcing the very behavior that is becoming problematic for the patient?
That's an excellent question. I'll take the lead on it. It's hard, it is case by case, certainly. And that's why telehealth is one of those treatment modalities that comes with a lot of benefits in terms of allowing people to access care. But I think with any new technology, although I guess it's not new anymore, but with any technology, we always have to be mindful of, is it appropriate, in this circumstance? And I think if you do have people who have, in this case, significant agoraphobia and panic attacks, who can't make it into the clinic or make it in to see a mental health provider, or a severe depression where they may not be able to get out of bed, this could allow telehealth. I view it truly as that bridge. I never want to bill it as like for some individuals, like this is a forever thing. I would much prefer in person, certainly for a myriad of different reasons. But if it's a means of potentially connecting with an individual who otherwise truly likely wouldn't be able to access care, I keep that in mind, and I continue to ask myself that question kind of throughout the care delivery, is that, am I potentially encouraging and reinforcing by saying, okay, yeah, you don't have to come in. We can do this virtually.
Gotcha. That is helpful. And kind of as a tack-on question to that one from the Q&A about, were you able to see and actually observe this patient and when they were exposed to anxiety-provoking stimuli? And also, how do you kind of maybe use the telehealth modality to also help with that assessment, because we may not be seeing the patient fidget right underneath the camera angle.
Yeah, so I'll take this one. I did witness him experience panic. It took us several visits for him to open his door to be able to go outside, so that we could have our sessions outside. And so I was able to take him through the exposure, panic, and then the box breathing and grounding exercises that we did, for him to be able to calm himself down. What I could not do is pair that with medication, because I didn't feel comfortable doing any labs or other workup for him. And that's how I had been taught to do exposure therapy, but so I had to modify it for him. And I agree with Dr. Alkis. This was always supposed to be a bridge treatment for him. Unfortunately, this patient was in the resident clinic, and we only have a year with these patients. And so I could not have the time to build that relationships to where I could then set boundaries and say confidently to him, I know you can do this. Let's meet in person, or let's meet at the PCP office, like I traditionally would have.
Mm. Okay, good points there. And you also mentioned something as well, that your traditional method of approaching that may have an inclusion of a medication or at least a pharmacotherapy option. And I believe that in this case, pharmacotherapy was not started for this medication. Could you possibly give a little more information about what influenced that decision?
I did start this patient on venlafaxine and SNRI, which he tolerated really well. I did not feel, I had thought about benzodiazepines. I prescribed him initially benzodiazepines, but so many of his exposures were with driving that he did not use, and I did not feel comfortable with him using the benzodiazepines. Because of the heart palpitations, propranolol is sometimes another option people think about, and I'd wanted to do that, but I did not feel comfortable without an EKG. So I felt as limited and trapped as the patient did, and treating him when it came to pharmacotherapy.
Gotcha. A shared helplessness at times, even. And oftentimes with exposure therapy, you're exposing them to what they're afraid of. Would there be any consideration of possibly having a family member include a telehealth visit while during a driving method, or during their time in the car?
Absolutely. And his fiance did would be in the car with him. The one time that she wasn't was the time he had a panic attack at the Dunkin' Donuts. But she was my ally in being with him during the exposures in the car. I didn't feel comfortable having telehealth visits while he was driving, even in his parking lot. So she would stand in and be that. And so having collateral for these patients, having someone that can be there in person, I think is a crucial element to this.
Very good. Very good. Well, these are all very good questions from our audience members. And I appreciate you both taking the time to do this presentation, and appreciate audience members for coming. Just a reminder, we do webinars every month. And so keep an eye out of what the next one will be from ACLP. You will find the actual recording of this on the ACLP website, on the social media platforms of Facebook, Twitter, now X, as well as Instagram. And we would be happy to see you again. But otherwise, I say have a good day.